While breast cancer touches so many people's lives, no two journeys are the same. But with knowledge comes power. Coming up, we'll hear from leading experts who are at the forefront of research and treatment, and listen to inspiring stories from survivors. Our goal is to help break down barriers and share vital information. Our town hall, from detection to recovery, navigating the breast cancer journey, is next.
Thank you to the Eunice Joyce Gardner Charitable Foundation for its leadership support of the Health Channel.
Welcome to our town hall, From Detection to Recovery, Navigating the Breast Cancer Journey. I'm Carla Hill. Joining us for this important conversation are here in studio Dr. Louise Morrell, medical oncologist and the medical director of the Lynn Cancer Institute, which is part of Baptist Health Cancer Care, and Dr. Sophia George, associate director of diversity, equity, and inclusion at the Sylvester Comprehensive Cancer Center, part of the University of Miami Miller School of Medicine, and Dr. LaToya Lewis, associate professor of nursing and health studies at the University of Miami. Joining us virtually is Dr. Hadas Kadar, fellow in breast surgical oncology at the Jackson Health System. Thank you all so much for joining us today. We begin with the importance of early detection. Finding cancer early offers more treatment options. You could say early detection is one of the best cancer-fighting weapons, and if you know your risk for cancer, you may be more likely to catch it early. Let's watch this package from the Cleveland Clinic about the call for early breast cancer risk assessment.
Living Minute, a look at the latest medical innovations changing our lives.
Breast cancer is the second most common cancer for women in the U.S. It's now recommended that all women get a breast cancer risk assessment when they turn 25, especially those with a family history.
Breast cancer screening should be highly individualized, just like all medical care should. So there's a few different things you look at. What age are you when we're looking at this information? If you have a family history of breast cancer, what was the age of the youngest person diagnosed? And then sort of what is the number that we calculate for your overall risk? And that tells us sort of which pathway to set on.
Dr. Peter says the average woman with no family history of breast cancer or other risks should start getting mammograms at 40. However, if a woman is at higher risk and depending on their age, they may have to start up to 10 years earlier. Dr. Peter says for anyone younger than 30, they'll typically decide on a case-by-case basis. What if a woman doesn't know their family history? She says there's genetic testing available.
Family histories can be complicated because some families either don't talk about those things. Some families, things might have happened generations ago. It might be things you don't have access to. And then there's folks that are adopted and don't know that family history.
Dr. Peters notes that most breast cancers are random. Only about 5 to 10% are caused by genetic factors. Early screening is crucial for those individuals.
I'd like to get our panel's reaction to that package. So let's start with Dr. Morrell. Dr. Morrell, what do you think about what was said in the video about early detection?
Well, I think this is the most important message that we should be talking about and never forgetting about, because the cure rate and the success and the degree of treatment that you even need for breast cancer is totally determined by diagnosing breast cancer early. And I think that in addition to sort of the mantra of mammograms, is remembering the other way to say what was said on this video is that 90% or so of breast cancer happens in women just because they're women and have breast tissue. And so we want to make sure that nobody skips mammograms, and that if they have missed a mammogram, don't be afraid, oh, now I've missed it, because once you get that clean mammogram, you're on a reboot, you're restarting, and you're at no more delay than anybody else. And then the flip side, what was being mentioned, which is really what I work on so much of the time, is how do we identify those women we're starting at age 40 doesn't make sense. Usually mammogram centers don't start doing that until, in addressing women, until they're 40 years of age, since that's the standard of care. But how do we find women 25, 30 years of age who either have a genetic predisposition or have very young cancers in their family, and give us a chance to find those very early? That's probably the hardest thing. So we do outreach programs, we try to do education, we try to screen people through their gynecologist, but that's one of our most biggest opportunities really to make a difference, is to find those young women that would be benefited from screening at 31, 33, 35 years of age.
Thank you so much. And Dr. Kadar, what do you think about the package that we just saw, and also, you know, Dr. Morrell's contribution?
Yes, so in terms of, I'm very happy that you started with this, because I think that one of the key elements is really assessing the risk before we decide on which type of screening we do. We have the screening for, you know, the average risk patient or woman, but we have to know and recognize the patients that have a higher risk. And we actually have a lot of calculators today that can really help us do that. And they look into, you know, a lot of factors, both genetic and family history and weight and you know, breastfeeding and in terms of menstrual cycle. And they all could give us an actual percentage of risk of each person, each woman, to have breast cancer during her lifetime. And this really helps us make the plan for screening. So patient with, or a female with high risk will have a completely different screening program. And I'm very happy you started with this, because this might resonate with more women and lead them to really explore their risk and hear from their family about family history and approach that to their doctors.
I'd like to ask Dr. George your thoughts on what early detection can do.
Yeah, so as others have said, it's really important that we know our family history and know our risk for cancer, for breast cancer specifically. And so some of our work has shown that based on where you're born, in particular, just like the Ashkenazi Jewish population, where we know that high rates of hereditary breast cancer, women, some groups from the Caribbean, like the Bahamas, Trinidad, Barbados, and others have high rates of hereditary breast and ovarian cancer syndrome, which means strong family histories, or sometimes that they're not fully aware of the family history. And so knowing your family history, having that conversation with your primary care doctor is going to be so important in terms of early detection and prevention.
Dr. Lewis, your thoughts?
So definitely in regards to all of these elements, as healthcare providers, our goal is also to demystify what elements are important and what is not as distinct. So most individuals are good with passing on information about their family history. However, there's some details about health history is sometimes gray and undiscernible. So the key thing is to talk to earlier generations about breast cancer, talk to individuals about healthcare prevention as a whole, and not wait until it's too late in order to address some of the risk factors and identify that.
Well, to help catch breast cancer early, here are the latest guidelines from the American Cancer Society. For women at average risk, women between 40 and 44 should get a mammogram every year. Women 44 and older can switch to a mammogram every other year, or they can continue to get them every year. Screening should continue as long as a woman is in good health and expected to live at least 10 more years. All women should understand what to expect when getting a mammogram and what the test can and cannot do. And, you know, according to the graphic that we're seeing on our screen, women at high risk for breast cancer based on certain factors should get both a breast MRI and a mammogram every year starting at age 30. The recommendation includes women at an increased lifetime risk according to assessment tools based mainly on family history. Those risk factors include a known BRCA or BRCA1 or BRCA2 gene mutation, a first-degree relative like a parent, brother, sister, or child with a BRCA1 or BRCA2 gene mutation, having radiation therapy to the chest before 30 years old. Lee Frenette, also the Cowden syndrome. Thank you, doctors. Appreciate you. And Banyan-Riley-Ruvalcaba syndrome can be a first-degree relative with those syndromes as well. Either a sister with one of those syndromes can be very telling as well. Some women at very high risk have opted to protect themselves by having preventative surgery to help their breast, and in some cases their ovaries and other parts of their bodies. The CDC calls them previvors. In this conversation recorded as part of the CDC's Bring Your Brave campaign, two women talk about how knowing their risk helped them make difficult decisions to protect their future. Here's their story.
I'm Nakia. I found a lump in my left breast at the age of 30. Had no idea that there was a family history of breast cancer. Just kind of living my life in my 20s, happily, blissfully unaware. And it was a benign tumor, and then found out that I am a carrier for the ATM gene mutation. So I'm a previvor. It's been about 4 years now of monitoring. Every 6 months I go in for imaging.
My name is Diana. I am 26 years old. I am a BRCA2 positive person. I am a previvor, so I found out I was BRCA2 at the age of 22. I was in my senior year of college. I was going to graduate, and then my life flipped, and I was like, okay, wait, what do I want? I have a family history, which is why I took the test, and I went through the double mastectomy and the reconstructive surgery at the age of 23.
I feel a little judged for wanting to get a mastectomy. It's maybe not the obvious choice, but the thing that's hard to explain to someone who hasn't gone through it is every 6 months having to deal with the healthcare system and showing up for a stressful ultrasound and mammogram as one of the youngest people there. And you're just laying there in a cold room, like, is today the day? Do I have cancer? And going through that every 6 months has just been horrible for me personally. Just the fear and the not knowing, and then how is my life gonna change, and just feeling like I don't have control.
I'm in my mid-20s, trying to explain this to a mid-20-year-old guy. It's hard to explain. I have this, and I'm gonna carry this with me. But I haven't had cancer, but I might get cancer, but I had the surgery, so I don't have cancer. But then there's other risk factors, but then there's like, I wanna have kids, but then they might get the mutation. Like, it's such a weird position to be in, kind of like, do I wanna be vulnerable, do I not? Like, does it worth it sometimes at this point?
Like, I could count on one hand the people that knew what was going on. And it was just because I felt as a previvor, like I shouldn't be taking up space or talking about this because I don't have cancer. And all of the things I'm thinking about getting a mastectomy would be preventative. And I'm so lucky to even have that choice. And so I've just been very timid to like share my story. And then I feel guilty for not sharing because it's like, this is my story and it could help somebody else. So I'm like, I feel guilty either way.
When I look at you two in particular, I look at this could be my daughter. After we found out that I had BRCA2, if it came down to it, there's a chance that I could have passed this on to her. But knowing that I can have her watch this and I can say, look, they did something before they got sick to advocate for themselves. That's what you did.
Those kinds of conversations really do mean a lot. Dr. Morrell, what makes preventative surgery an important option for women at high risk?
I think the entire value of testing and trying to detect a predisposition gene, which is really what those genes are that these women are describing, is on what are the actions that I can take. So a lot of people will do tests. I had somebody today who did a big panel of 200 genes, and half of them that she had findings on, there's no action. So we really want to focus on where knowing this information can make a difference. I think the second thing that's really great about genetic testing is that unlike being diagnosed with cancer and now you have to make a decision and you have to make a plan, you have the time to get the information. You have the time to figure out for you, just as is commented on that report, to figure out who am I and what is this going to mean to my life? Because for the most part, it isn't that you must remove your breast tissue. Even if you have BRCA and an 80% chance, some of those women are still going to take the choice of high-risk screening, but that's also incredibly valuable. And so it gives you the time to learn a lot about it, to learn about yourself, to learn about the surgery, to learn about the consequences of the surgery, and to really, what I urge with my patients, because I have this discussion pretty often, is to talk about the fact that you have permission to do any of these choices, not to listen to all the voices around you, but to investigate for yourself. Do as this person in the video did. She tried the route of doing screening, and it was just tormentor for her. But it's not torment for everybody. In fact, I have many patients who've done this for 25 years and remain comfortable and reassured and aren't distracted by it. So I think it's great to be able to get that information and then to get really accurate information and to sit with it and to talk to the surgeons and to learn about your options. We are not doing this test just to remove organs, but to make sure that we're doing everything that we can to optimize the lifelong survival that these women should expect to have.
Very good point. And on that note, I'd like to turn to Dr. Kadar. What about preventative surgeries? You know, how effective are they in your medical opinion?
So preventive surgery is actually called risk reduction surgery, and we can offer that to patients who have a higher risk, or according to what you said, genetic disposition or other risk factors. And in that surgery, we basically remove the breast tissue. Sometimes we can preserve the skin, and that lowers the risk of developing breast cancer, but it does not eliminate the risk entirely. And that is because we have still microscopic breast tissue that we are not able to remove or see completely during the surgery, and therefore there are some breast cells that are remaining. But definitely the risk drops about 90% to have breast cancer. It's very important for me to say that it is not typically recommended for the women with average risk in this panel.
Thank you. Dr. George, can you talk to us about genetic testing and all of this?
So as we already heard, you know, it's learning about your genetic risk, especially when you have a strong family history or any family history of cancer. You already indicated leukemia, Down syndrome, hereditary breast and ovarian cancer syndrome. There are many genes that, about 13 genes that are known to increase your risk significantly for breast cancer. But as Dr. Morrell said, that there are many genes on these panels now that we are testing for that we don't yet know explicitly the impact of those having those mutations. I would add that there are different types of mutations. So there are pathogenic mutations that we find that causes an aberration or a breakage in the protein so that the gene kind of do its job of repairing DNA. And then there are other things that we find that are called variants of unknown significance. That means that we found something but we don't know what it really means. And so you have to consult with the doctors, your genetic counselor, to find out like how are you going to still do your screening, especially if you're in a high-risk family or have a history of breast cancer. I would also add that historically, we've not had a lot of diverse people participate in genetic testing. And so a lot of the work that we are doing at Sylvester is to increase the number of women and men who are undergoing genetic testing so that we identify those gray areas of the unknowns. There are lots of families that have high rates of breast cancer, and we find these unknowns, and we want to know, well, are they really unknowns, or is it because it's not represented yet in the databases? So it's really important that you consult with your physician, again, talk to your family members, and participate in genetics testing if available, and hopefully it is, we're in the United States, available to you so that you can know your risk and figure out ways to reduce your risk as you've already indicated today.
And Dr. Lewis, any thoughts on what we've just seen and heard?
Yes, definitely. Part of the collaboration with the National Institute of Health and the National Black Nurses Association was part of the element of bringing together individuals who are underrepresented and encouraging them to be part of testing as well as part of the database and healthcare research. So I would say that's one element. And the second element through the video was advocacy. So I would encourage anyone who is concerned to talk to their nurses, talk to their healthcare providers, talk to other individuals in the community to help provide a support system. As we saw in the video, many individuals felt that they were left by themselves and guilty for doing certain actions or waiting on certain actions. So definitely I would recommend that.
Much appreciated. You know, there's a disturbing trend in cancer. More younger people are being diagnosed. That's certainly happening in breast cancer. Travel nurse and survivor Taylor is open about her experience being diagnosed at age 25. Take a look.
I'm Taylor. I'm 27. I am a year and a half breast cancer survivor. I was 25 when I was diagnosed.
I can't imagine, I was 31, but finding out you're in your 20s.
But I think like in your 20s and having had a mastectomy, learning to like look at your body in the mirror and you can feel and what you can't feel and realizing like, oh, I can't feel a whole part of my breast. And then you tack on medications. So with the low to no estrogen in your body, like your libido is naturally being inhibited. You're trying to figure out yourself and what works for you intimately while you also maybe have a partner doing that. I'm a travel nurse, so when I got diagnosed, I ultimately decided I needed to move home for treatment. And so at 26, I moved back in with my parents and kind of felt like a child again, giving up all the independence, especially when you physically need the help from them. And it makes you emotional no matter how much time goes past, but you know, and you think, I'm 26, and if I want to connect with my mom, how do I tell her, like, you need to spend more time thinking about the possibility of your child dying, you know? That is a pain I would never wish on somebody. I remember a few weeks ago, I started meeting with a new therapist and she asked, like, do you think it's made you a better nurse? And like, without hesitation, I could say, yes. The people at your appointments who make a difference, you know, the nurse who's there who tells you, like, I had breast cancer too, or, you know, I remember when I went for my mastectomy and the anesthesiologist was maybe 40 and a breast cancer survivor, and just to hear her share that before going in for a mastectomy at 25, it changed the course of the day for me, and it's something I remember now. And so when I think back on some of the situations I used to sit in and the lack of care or attention I paid to the person who's laying on the table, it's something I think I'm pretty ashamed of. But when I think about the life experience that this has all given me, I know what it feels like to want any sort of relatability or to just have your hand held when somebody's doing a procedure. I think is like a different sense of identity I think I carry with myself at work now. To a young woman, if diagnosed, I think I would just say, like, the fighting is a lot easier than the surviving, in my opinion. What comes after, when there's no more plan, when there's less frequent doctor's visits, when there's less support from the people around you, and set yourself up for success. Learn to be vulnerable, learn to tell people when you're really not doing as great as it might seem on the outside, and learn to just be authentically you.
You know, we have some really wonderful viewers that are joining us, and Dr. Morrell, I'd like to share a question we just received from Anissa. She asks, if someone got diagnosed with stage 2 and had her auxiliary lymph nodes removed, is there a chance of reoccurrence?
So she has already done the treatment and she's now thinking about, well, okay, what did this do for me? When I sit with newly diagnosed breast cancer patients, we know that they're going to meet with, and they do in one setting, a surgeon, a radiation doctor, medical oncology, genetics. That's because we're trying to accomplish one thing, which is the best possible outcome. And how I would describe that to them is, we need to get that cancer out, we need to make sure it doesn't return where it started, and we need to make sure it never comes back and doesn't spread anywhere else. And if all those things happen, it's out, it doesn't come back, it doesn't spread, you're cured. The dilemma, the emotional dilemma especially, is once I've taken all my steps, how do I feel, when do I get to feel free? When do I get to be done? When do I get to say, oh, this is it now, it can't ever come back? And unfortunately in life, nothing is quite like that. But we know that that number is very low, especially when you look at it on an annual kind of basis. And so if you think more, this is 99% likely not to happen this year, and this is 99% likely not to happen this year. And once you get for those 3 to 5 years, that's also quite true. So even though that we're not perfectly ever going to give you a complete off clear, there's so many things that could happen. The focus should be on what's my odds now that I've done everything I needed to do. And that's how I would look at it. That I can't tell you it can't ever happen again, but a lot of things could happen, and the fact is the odds are overwhelmingly favorable that it's not going to come back.
Well, that's good news. Dr. Kadar, we have another question, and this one's from Khan. My sister-in-law has stage 3, and Khan would like to know, what are the survival rates?
Well, it's very difficult to give an answer like this without knowing the details. But I will tell you that we have very, very good treatment and very good advancement in treatment in the past year. And we see that a lot more patients are curable and operable, actually. For example, patients that a few years back would not be even considered for operation today are managed to reduce their tumor and shrink it, and we can operate them today. So it's very difficult for me to say an exact number, but she should, if she'll follow up with all the treatment plan, I'm sure she has a good chance.
Dr. Kadar, thank you so much. We know that you have to run. We thank you for all that you're doing in this area of breast cancer. Thank you for joining our panel today.
Thank you very much.
And you know, Taylor's experience provides such valuable insight. There is no one-size-fits-all treatment. Each person's cancer journey is their own individual experience. Let's get reaction from our panel with regard to Taylor, the traveling nurse. Dr. Lewis, I know that in your line of work, traveling nursing is very common. But how important is it that nurses take time to relate to their patients? What do you tell your students?
Well, we usually tell our students to be empathetic, but we also tell our students to listen. There are times that our patients, when they're going through different transitions in life, whether it's a diagnosis or it's other aspects of their life, that we tell them to just listen and see what the patient needs. We also mention aspects of holistic care. So not only addressing the physical components, but let's address also the psychological components, the psychosocial components, and then address the family members, because caregivers also are taking part in this process. So how do we look at everyone that is impacted from this and focus on daily things that make that patient happy, make the family members more unified, and can create better psychological outcomes?
Dr. George, if a younger family member is diagnosed, for instance, should her family members be tested?
Yes.
Yes, one short answer.
Yes. Definitely. Again, thinking about what Dr. Lewis said in terms of seeing a person as a whole and being holistic, it is important for us to think about the entire family. You know, we don't necessarily know exactly why a particular person has develops cancer, but for sure, once they have cancer, doing the standard of care things like getting genetic testing so that we can at least rule that component out is super important for the rest of the family for prevention.
Great suggestion. We do have another question, and this is from a 60-year-old viewer. She writes, I was diagnosed with triple-negative cancer right at the beginning of the pandemic. I had surgery, radiation, and chemotherapy, and it's been almost 3 years, and the cancer has not returned. Her doctor is happy, but he's still very concerned when she comes in for her follow-up visits. Will it always be this way, particularly with a triple-negative cancer? But before we go to the panel, we have a short video package here that explains what triple-negative cancer is. Take a listen.
You know, when I first heard the words triple-negative, I thought, well, that's good, right? But it turns out the negative is referring to what treatments you can use to fight the cancer cells. Think of a cancer cell as like a house. We want to get into the house to destroy the cancer, and there are 3 locks on the front door: estrogen, progesterone, and a protein called HER2. If your cancer tests positive for any of these 3 locks, what they call receptors, then doctors have a few possible keys, like hormone therapy or other drugs they can use to get inside the cancer cell and destroy it. But if you've got triple-negative breast cancer, it means those 3 locks aren't there. They're not on your door. So the keys the doctors might normally use won't work. Fortunately, chemotherapy is still an option, and an effective one.
That's a great explanation. I want to slip in here that this is a personal show for me as well. I was diagnosed with triple-negative cancer twice, 2005 and 2007, but I want to know that you all are not alone, and I'm living the triple-negative life, so to speak. Let's hear from the panel, though. Dr. Lewis, a recent study found that African-American women had a 3 times more chance of living or being diagnosed with triple-negative cancer. Have you had any cases, or have you talked about any of the theories as to why?
Well, there are aspects that are inherited. There are genetic components that relate to the triple negative aspect. In addition to that, we can look into other aspects of diagnosis, we can look into aspects of resources. So there are a variety of components, as well as looking into health history. That's another component in regards to the triple negative and how it is impacted.
And Dr. George, we talk about triple-negative cancer, but what does that mean for the makeup of the tumor?
So triple-negative breast cancers are, we say that they're aggressive. And what does that mean? It means that there are a lot of mutations, that the DNA in these tumors, they have typical mutations in genes that are usually thought of as stopping cells from growing. And so those, when they're mutated, cells just grow uncontrollably. It also means, as the video showed, that they don't express these proteins, these locks, that we are now we have no way of opening those locks because they don't express these proteins that have very, very good treatments against it. It also means that sometimes these tumors are highly inflamed. In particular for breast cancer, it's an opportunity for targeted therapy, actually, in that context, or immunotherapy specifically. And it means that women and men are under vigilance to keep monitoring and checking, as you just indicated, to ensure that this thing doesn't come back. And if it does, when it does, that we know as soon as possible so that we can use another form of treatment.
And Dr. Morrell, if I saw you in 2005 and 2007, when I was diagnosed not once but twice with triple-negative cancer, how do you counsel a patient like me or someone that's watching
I love
today?
that story. I love your story because, as we've indicated, this is a type of cancer that can reoccur. That's what aggressive means. It can grow fast. And it can be quite difficult to treat without all of these tools. And this is probably our most exciting, latest area of progress in breast cancer, because we learned about the targets for hormone receptor positive for 25 years. We learned about and got a tool for the HER2, and we were sitting with the triple negatives and said, chemotherapy, when you had it, that was sort of all we had. And now We have had a huge breakthrough with immunotherapy, and for the first time in my 30-year career, this is also a disease that we can plan to cure. And I think the one good thing in the answer to the question here was, because this is a fast-growing tumor, if it's going to come back, it's going to come back in the first 3 years, and by 5 years, this is not going to come back. So the good news is that we do have much more confidence that this is completely cured now at this time as a result. It also is, as you've indicated, Dr. George, a more genetic, and so every woman who has a breast cancer and is triple negative is now advised to undergo germline or genetic testing to see if this is an inherited form, because there are targets in the BRCA gene that we can also use medication for and prevent it from recurring.
You know, that is very exciting. As a cancer survivor, I remember for both of those cancers, they were kind of like, well, live well, see you at your next checkup. So to hear that so many advances have happened, thank you for sharing that with all of us. The most difficult cancer to treat, though, is late-stage disease when the tumors have metastasized or spread to other parts of the body. Let's hear from Megan, a stage 4 breast cancer patient. She's a survivor who is actively learning how to navigate the twists and turns of this condition. Listen to her story.
Hi, I'm Megan. I was probably 29 at the time that I started getting like a weird pain in my chest that wasn't normal for me. And I had a lot of barricades trying to get to a doctor. I didn't have insurance at the time. I didn't have a doctor I could go to. So I finally saw one, and they kind of dismissed me because I didn't have a family history of breast cancer and because of my age. So it took a long time for me to finally go to another doctor and get diagnosed. But I was diagnosed at age 30 with invasive ductal carcinoma. I went through chemo, double mastectomy, radiation, reconstruction, and then I was living blissfully, no evidence of disease for like 4.5 years, thinking, you know, cancer was behind me, and then I felt a pain again, which ended up leading to a secondary diagnosis. So I have metastatic breast cancer, or stage 4 breast cancer, and people don't know how to support you when you're stage 4, because they go, you might need a wig, or, you know, you might need a meal train. But when you're like, I'm gonna need support for the rest of my life, I don't even know how to communicate how to support that. You know, I'm still trying to figure it out. And even when you don't have stage 4, cancer is a life sentence. You don't get to like just say, I'm over and done. You're always getting a test. You're always keeping it in the back of your mind. Because me keeping cancer in the back of my mind is what is making me be so well now as a stage 4 cancer survivor. Because I noticed my signs and I said, I have to go get tested. Something's not right. When it comes to work-life balance, I can't work full-time because the disease is where it is. And also, like, my participation in clinical trials, like, there's no 9 to 5 that would be like, yeah, take every other Tuesday off, and, you know, every other month take all this time off for tests. But the thing, I don't, like, hustle at jobs anymore, but I do, like, hustle at time with the people that I love. And I do prioritize that. And even my husband could definitely work more days of the week, but we're like, you know what? Like, time is our currency. I'm metastatic, but I could live a full life. Like, I'm hopeful for that. What I can do is I can prioritize time with the people that I love, and I don't think no matter how much time on earth I have left, I don't think I'm ever gonna be sad that I made that decision for myself. Now I might not have all the money in the world, but, you know, I am prioritizing happiness, and I am happy at the end of the day.
Wow, we're all so moved by Megan's story. What a brave woman. I'd love to get the reaction of the panel. Dr. Morrell, it's always tough dealing with stage 4, but there are a few treatments now, yes?
Yeah, there's no way to say, oh, yay. This is a terribly difficult journey and shocking. And when you hear a story like Megan's, this is all of us who do oncology. This is the story. This is the life that drives us and makes us realize how amazing people can be when they're facing something as challenging and difficult emotionally as this, and how we all need to live our lives, you know, with purpose and with enthusiasm, and it's why we do it. So But I also reminded of one story, and this is where I start my journey with a lot of patients when they hear this news. I had a woman that I had treated for very aggressive breast cancer when she was in her late 30s, and she had 23 involved axillary lymph nodes, which is a later stage, and she went through the treatment at the time. And 5 years later, it showed up in her spine. And she was the mother of 3 small girls when I met her. And I was not in the same location, so she came to me for a second opinion after she had started her treatment, and she and her husband said to me, well, I asked what was my survival, and they told me 18 months was the average survival for her stage of disease. Well, that was in 1995, wow. And she's still alive today and has never relapsed since that time. So we always want to remember that those are just numbers, and we can keep hope for a very, very long time. And so, as many of us know, living with cancer is a different kind of potentially chronic disease, as burdensome as it is, as Megan said in her story, of having to go through the tests, of having to be afraid of what the results were going to be. And that's because treatments have advanced. And to be honest with you, I've seen this now that I've been in this field so long. 5 years go by, maybe it shows up again, and guess what? There's been 2 new treatments for that. There's been another treatment, and so every 5 years, every few years that you can get the treatment options and the choices, even sometimes resecting small areas of residual cancer, we've seen people live a long time. So the best that we can do is maybe a lot better, and bringing that positive attitude and bringing all the support people that you can into that, who also see the hope that comes from that. It's still really a positive message, but we have a lot we can do, and then the research that's so important that has made this all possible, because that's really what we're seeing is the fruits of years of research that are now giving people many years.
Indeed, indeed. Speaking of research, I want to come back to you, Dr. George, and considering Megan's situation, how does genetics play a part in this? Or, does it help with anything?
So I'm so happy she talked about clinical trial participation. So genetics, again, we've talked about the mutations and the aberrations and changes that are happening in the cell, and metastasis. Unfortunately, we know that different regions where the tumors go, they are almost their own thing. And so the participation in research is so important. So that we can actually see how the work that we're doing in the laboratory, when we work with our clinical colleagues to implement these new treatment programs, that to see how effective they are. We need the participation of women and men, like Megan, so that we can improve life for herself and others. And we know that participation in general in clinical trials improves overall survival of individuals. And so yes, so genetics, the tumors, and that's why they metastasize, they keep evolving into making different changes in the DNA so that they can survive in the new location. And so we keep chasing that with different modalities, as Dr. Morrell said, so that every time there is a recurrence, there is something new that we can treat the patients with.
I want to insert, I've seen for myself the importance of clinical trials. My mother is a breast cancer survivor. The treatment she had in the early 90s is now commonplace. So those of you watching, if your medical team talks about a trial, say yes, because you don't know how you're helping and how common it will become to help save your life and others. So thank you so much. Dr. Lewis, in treating patients with stage 4, what do you tell your nurses, or what is the training that nurses receive in helping patients at this level of cancer care?
Yeah, that's a great question. So we commonly incorporate the concept of multidisciplinary and interdisciplinary care. We focus on essentially training nurses so that they receive the appropriate information regarding the different levels and different factors regarding this patient's care. In addition to that, it's incorporating other aspects of quality of life. And my colleagues have been mentioning quality of life is an important element. But we also don't want to give give false hope, but we want to give hope. So there's a clear balance in between the two, that we want to create realistic outcomes, but we also want the individuals to enjoy their day-to-day. So a part of the nursing aspect includes medication management, patient care, looking at outcomes, collaboration, as well as other aspects of incorporating any other disciplines that can help with resources to support the patient and their loved ones.
Hope. We could do another show on mental capacity, putting yourself in a in a place of wellness, but that we're going to bring everybody back to do that show. But in all seriousness, being diagnosed with breast cancer can take a heavy toll on relationships, especially intimate relationships. And in this next package, we go back to bring the Brave campaign to hear survivors talk about navigating relationships while undergoing cancer treatment. Let's take a look.
When I was first diagnosed, I was married. And then, I don't know if you felt this way, but like after everything I went through, like literally felt like I became a new human, and I kind of knew what I needed and I knew what I deserved. And I was like, all right, I'm out, like starting fresh. I went on a blind date. My goal was I want to give him all of my stuff. I wanted any relationship that I had after cancer to be just honest. Here's all the reasons why you should run. We were both so open. We shared things with each other that we would never normally tell the other people right away. And we fell in love.
It's beautiful.
I know.
You know, I was 31 when I was diagnosed, and I had just met somebody. I was really feeling dude. And so I'm like, how am I gonna tell this man that I have breast cancer? And we've only known each other a few months. And I was scared. I was really, really scared. It was just a really confusing time with dating. And fast forward to 10 years later, it's still a confusing time for dating. I have menopause symptoms, but I still have a cycle. And that's annoying as all get out. And I'm like, pick one, please. So even laying next to somebody, I feel insecure in a way, because I'm like a sweating, wet mess. And you don't want to feel like that. That's not sexy.
Sharing your body with a new human is so difficult. How do I explain I don't have a nipple? How do I explain I have no feeling in my chest?
Yeah, you think you're doing something, but you're not.
It's for you.
I'm a previvor. I'm in my mid-20s trying to explain this to a mid-20-year-old guy. I'm like, do you know what BRCA is? This isn't gonna come up on a first date from a dating app. Like, I'm not gonna be like, so, guess what, you know?
Obviously, I think Kadar and I are similar in that, like, you factor in being in your 20s, and it is maybe even harder battle of like dating and like apps these days, social media. So like I am queer, which brought a whole new level to it in terms of being, you know, with a woman at the time. I didn't have that, like, I need to explain to you what breast cancer is. I think instinctively, like, a woman does understand that. On the flip side, I don't think I was prepared for, like, how sad that could be if, like, I'm now seeing another woman's body, or that she does not have a mastectomy, you know? So that is, in itself, a little heartbreaking, but ultimately my relationship, I think, was a me problem. Sometimes good partners are coming in our life and we're the problem because we just went through this ridiculous thing that we haven't processed yet and don't really have a timeline for doing so, and somehow adjusting to that is tough, I think.
I think for me, I've had so many surgeries. My body is covered in scars, and I told my therapist I felt like I looked like a monster, so I didn't want to try to have a relationship with anybody and then be able to see, because it's one thing to tell somebody what you went through, it's another thing to show them. I would like to meet somebody, but it's hard because you can only laugh your way into so many things. I can tell a mean joke, but I can't take my clothes off and be happy with what I see. So how can I expect somebody else to be happy with that?
Just be patient with yourself and give yourself grace. Because the reality is, people don't get it.
They don't.
They don't get it. These conversations are needed for young women to know that there's a community of women that you can come to and talk to and reach out to that are going through the dating scene, are trying to figure out who they are with this crazy, unfair disease. Being a part of this sisterhood, because we're warrior sisters. This is community.
What a powerful conversation, and the vulnerability of these survivors and previvors. So let's talk about this with our panel. And let's start with Dr. Morrell or Dr. George or Dr. Louise. I mean, we were laughing and crying all at the same time. The thoughts on relationship, it's not the first conversation that is had with a cancer patient, yet it is still a very important part of our human existence. Hopefully, like, triple negative, there's been some
progress,
ingenuity, some progress.
Yeah. So one of the things that at our Cancer Institute that we have actually even just recently launched, and it just comes to mind here, because we called it a bridge program, and the concept was when you enter a Cancer Institute, or you enter somewhere where you're getting your care, you have a whole life that you had, and suddenly we at the Cancer Center expect you to just figure out how to make that life fit with what we're telling you to do, and it's going to be so different for different people because the lives that they have. Are they raising children? Are they taking care of older people? Is it that they're working? A lot of these things were brought up, and that whole life is still there and has to be part of the new steps that you have to take. And what was so striking to me in this video, and so vulnerable of these women to talk about, because it was such an honest discussion, is that then you have the life after, and you need the bridge after. And let's face it, the doctors are useless because we're so focused on obviously very important things, but it really means you need a whole team of people, and you need to find the person, you need to find the people who care about all of those aspects. We all care about it, but that it may not be your nurse or doctor. It might be. It just depends on your circumstances. But your support groups may be the best source for that. We have therapists that are particularly focused on sexuality and normalizing your sexual life. But of course, again, the combination of medications and physical activity, and what are the things that we can do to make you feel well, because ultimately that's the thing that's going to help with all of these relationships. And focusing on all of that and getting to a cancer center environment, or getting resources that address not just the technical medication, but the health and so forth. So I'll let the other people talk, but I think this was just a great video to talk about that.
I want to insert, we got another question from one of our viewers, and they want to know, why is cryoablation not used more for tumors? Anyone can address that?
So I will briefly do it. Cryoablation can kill cells, so they can kill cancer cells. But for all of you who've been through breast cancer, we want to know, did we get it all? Did we get the margins? So if you go in and you zap it, but you don't remove the tissue, then you don't know if you got it all. So it's being investigated, because in other tumors and other areas it seems to work, but most of the time you do cryoablation, you still have to radiate, and you don't have as much data to tell you. So it's a consideration, but if you think about a simple surgery to remove it and get all the information and get margins, is going to be the standard for a while until we can prove this is actually better.
Thank you for that. Thank you for addressing that question. Dr. Louise, Dr. George, going back to relationships and intimacy in terms of cancer patients, your thoughts?
There's one I
was just going to say, at least at Sylvester, we have a survivorship program that, as we say, the survivorship starts at the time of diagnosis. And so we have a sex therapist, and we have a surgical oncologist who is focused on sexual health. Her name is Dr. Christine Rojas. And so it is very, very important. The medication that we are taking, or the women take, it affects, as she said, one of the people said, it affects their hormones. She feels like she's going through menopause. And that also affects your ability to be intimate. And so We're trying to do this in a holistic way, and as Dr. Morrell said, that we have to take the holistic approach for everybody.
Mm-hmm.
Yes, and finally, in addition to my colleagues, mindfulness is something that we've incorporated with different breast cancer survivor patients and other oncological patients to help them accept who they are, live in the moment, live for today, not for the past and the future, but enjoying today. So that's also an additional aspect to support these patients.
You know, and before we leave today, we want to make sure that for people without insurance or those who can't afford it, the Florida Health Department provides screening at no or low cost. And for those who are diagnosed with cancer, the cost of treatment may be covered through Medicaid. You can email questions to cancer@flhealth.gov. It's on your screen right now, and the phone number is 850-245-4144. We are running out of time, but don't forget, contact the Florida Health Department Cancer Program. Again, 850-245-4144, cancer@flhealth.gov. This panel could go on forever. What I enjoy most, ladies, is that we're leaving with hope. I'd like to thank our panel again for joining us, and to our audience, thank you for watching. We hope you found this town hall helpful. I'm Carla Hill. Thank you so much for being with us, and I'll see you next time.
Thank you to the Eunice Joyce Gardner Charitable Foundation for its leadership support of the Health Channel.